Hello everyone. We are now going to go over the flow cytometry of the bone marrow from a 52-year-old man who presented with pancytopenia. So let's start with CD45 versus site scatter. The population that is labeled here in pink and red are the lymphocytes which have the brightest CD45 and low site scatter. There are very few cells in the monocyte gate here which have bright CD45 and slightly higher site scatter than the lymphocytes. The cells painted in green here are the granulocytes in various stages of maturation. They have dimmer CD45 than lymphocytes and monocytes, and they have very high site scatter. The cells in the blast gate are painted in maroon, and these cells have low CD45 and low site scatter. So let's see how much these cells account for in the entire sample. So in our table, it lists that these are 1.9% of all cells, which is still within the normal range. But we have to remember that we should not use flow to obtain the numbers. We have to use our differential count for the numbers. The characters of these cells, as seen in the table, is that these are CD34 and 117 positive. So let's trace our blasts and also the other cells in these tubes. So the next plot is CD34 versus site scatter. Our blasts are CD34 positive, as we expected. They are positive for CD38. So normal blasts do have CD34 initially, and they're negative for CD38. Then they acquire CD38, and they slowly go this way, where they just have CD38 and lose CD34. So normally you'll see like a pattern going from here all the way here. That is kind of a little bit missing, but again, we cannot say anything from that alone. We have to keep looking, but so far, that's one thing that is abnormal. And CD56 is negative, HLA-DR is positive, these are just normal. 123 is negative, CD7 is negative, CD117 is positive. So all that is normal. Now, if we look at other populations, our granulocytes express CD38 as we expect, so normal. And the cells labeled in pink express CD56, so those are the NK cells. And otherwise, nothing else really stands out as abnormal in this tube. Moving on to the second tube, which has more markers like CD10, CD13, 11B, and CD16. So this tube helps differentiate between the immature and the more mature granulocytes. So the mature neutrophils are painted in green, and you can see that the mature neutrophils express brighter CD45 than the immature ones, and that is normal. And the immature ones are here painted as dark green. And again, you can see the lymphocytes here, monocytes here, and the blasts here. And in this tube, the blasts account for 1.2%. So now, when we look at CD13 versus CD16, we see the mature or the mature granulocytes or the neutrophils express bright 13 and CD16. So that is normal. And also, we see that our mature neutrophils express high site scatter as expected. So that is also normal. What is abnormal is that our immature granulocytes are all CD13 brightly positive. Normally, in myeloid maturation, you will see a population that is CD13 positive and CD16 negative, which are the promyelocytes. And then there will be a population here, which is losing CD13 and still negative for CD16. Those are the myelocytes. Normally, your myelocytes should sit here. And then they will, excuse me. And then they will slowly acquire CD13 and CD16 as they become metamyelocytes and bands, and your mature neutrophils will express the brightest 13 and 16. So normally this 13 versus 16 graph will look like a Nike swoosh or a tick mark. So you'll see a population starting here, promyelocytes, then the myelocytes will go here, then the metamyelocytes will go here, and then the bands and neutrophils will be here. So that is missing. So that is called as asynchrony in the maturation pattern between 13 and 16. So that can be seen in dysplastic granulocytes. And again, in CD10 versus CD13, we see that the intensity of CD10 is kind of lower than what we expect for neutrophils. Neutrophils express bright CD10. We usually see them a little more on this side, so this is kind of a little low. Again, there will be in 13 versus 10, you'll see a population here, here, and here. Like again, the myelocytes which used to sit here are absent here. I mean, it doesn't mean they are absent. They just don't lose CD13. They still have CD13 expression, which is abnormal. So instead of seeing a shape of a gun or something, you just see a straight line, which is again abnormal. 16 versus 10. 16 is normal, but 10 is a little dim. So that is again the same thing that we saw here. 11B is the brightest in neutrophils, so that is normal. We see that here. And then 11B is usually negative in the promyelocyte stage. That is also normal. 11B is slowly acquired in the myelocyte and metamyelocyte stage. So you still see some immature granulocytes or the dark green population that are variably positive for 11B. So 11B acquisition is still normal. But in 13 versus 11B, you always see like a thyroid shaped structure because you have cells that are negative for 13, which will sit here. So that is absent. That is abnormal. So basically, all these graphs look abnormal or have a different shape than what we are used to seeing in normal marrows, because none of them show the population with loss of 13. Or in other words, the myelocytes do not show loss of 13 as they should. 11B versus 16 is just normal. Everything else is just normal. So in this plot, the thing that we see is no loss of CD13, which can be seen in dysplastic granulocytes. So in the same tube, now they are characterizing the blasts. We can see that the blasts are CD34 positive. They're negative for 11B, and CD13 versus 34, you see that inverted C shape very nicely. That's normal. The blasts are CD33 positive, again normal, negative for 14. A small spray in 64, which is normal. HLA-DR positive, normal. Negative for 10, that is also normal. So everything is essentially the same. So basically, so far in this one, we see that the blast numbers slightly increased. Usually when a normal bone marrow is subjected to flow cytometry, we'll see them less than 1%. This is like more than 1%, slightly high. And then we saw that the blasts do not acquire CD38. I mean, they acquire CD38, but they do not lose CD34 as they acquire CD38. So that there is a little asynchrony there. And then we saw that there is no loss of CD13. So there is asynchrony in the maturation of the myeloids. Those are the abnormalities we see here. So the final diagnosis in this case turned out to be MDS, myelodysplastic syndrome, but that's a rule of diagnosis. You cannot make that diagnosis just from flow cytometry or even just from marrow. You need a lot of other information to make that diagnosis. The diagnosis that we display in this blue box is the final diagnosis on that case that turned out to be. It is not necessarily the diagnosis that we made on the flow cytometry. So when we report flow on cases like this, we will just say abnormal myeloid maturation pattern with no increase in blasts, because the blasts were not increased and they do not show any clear, any definite aberrant expression, but the myeloids show abnormal expression for CD30. That's all we are going to say. And we are going to say that this indicates that there could be a primary marrow disorder, such as myelodysplastic syndrome, correlated with morphology and other ancillary studies like cytogenetics, FISH, and molecular studies. So myelodysplastic syndrome can have various presentations in flow cytometry. So let's go over each cell and discuss what abnormalities can be seen. For erythroid lineage, they can show there is a decreased expression of CD71. In the myeloid lineages, like I said, there could be asynchrony in the acquisition of 13, 11B, 16, and 10. And if you remember, your dysplastic granulocytes often have low side scatter and they have hyposegmented lobes. So those are the elements that contribute to side scatter, the complexity of the cell and the granularity. So when both of them are lacking, so when the cell is hyposegmented and hypogranular, the elements that contribute to side scatter are not there. So their side scatter will be very decreased. Sometimes they even creep into the blast gate. So That is another thing that you have to keep in mind, that site scatter will be decreased in dysplastic granulocytes. And there will be asynchrony in the acquisition of all those markers. Now, coming to monocytes, monocytes can have aberrant expression of CD11, CD117, or they can have expression of CD56. Again, there can be asynchrony in their expression. Asynchrony in the expression of both granulocytes and monocytes, in a sense, like, you know, as they mature, they should lose some markers and gain some markers. For example, myeloids, when they mature, they lose 117 and they gain the more mature markers like 15. So when a granulocyte is expressing both 117 and 15, or 34 and 15, that is asynchrony. So you will see those kind of expression. And when similarly for monocytes, they should not express CD117. The monoblast can sometimes express 117, but then as they mature, they don't express 117. But when you see both the mature markers and 117, that is asynchrony. You can see that, or there can be aberrant expression of 16 and 56. When it comes to blasts, the blasts can show loss of CD33, they can show loss of CD38, or they can express CD7 and CD56. CD7 and CD56 aberrant expression is very common in cases with myelodysplastic syndrome with excess blasts. So again, when we write the diagnosis, we don't commit to it, we just give a descriptive diagnosis. Thank you.